Welcome to this Step 3 review on Obstetrics and Pediatrics case strategy, brought to you by Roadmap to Residency. Our goal today is not to reteach the medicine, it is to show you how these question stems are built and how to attack them, using 4 classic cases you will meet on test day. Make sure you are also working through your question bank and a solid review resource alongside this video, because these patterns are best learned by doing questions. Let us get started. Here is our plan. First, we will read each obstetrics and pediatrics vignette like a physician deciding what to do next. Second, we will practice separating the sick, unstable patient who needs immediate action from the stable one who can be watched. Third, we will walk through 4 high-yield cases together: preeclampsia, postpartum hemorrhage, fever in a young infant, and asthma in a child. For each one, we will explain exactly why every answer choice is right or wrong. This video assumes you already have the content from your review resources. We are here to sharpen how you take the test. Strategy 1 is to read for the next best step. Start with the last line of the question, because that sentence tells you whether you are being asked for the next step, the best test, or the first line treatment. Then go back and hunt for the severity triggers. In obstetrics and pediatrics, the exam plants specific numbers and findings that flip the answer, like a blood pressure threshold, the age of a febrile infant, or how much blood a mother has lost. Circle those details as you read, because they are doing the real work in the question. Strategy 2 is to separate the emergency from the stable patient. Before you look at the choices, decide whether this mother or child is sick or stable. Severe range vital signs, a toxic appearing infant, or ongoing bleeding push you toward immediate treatment. A calm, well-appearing patient with normal numbers points towards simpler care and follow-up. Then make the answer match that severity. Most wrong answers on these topics either treat a mild case too aggressively or watch a true emergency for too long. Grade the severity first, and the right answer gets much easier to see. Strategy 3 is knowing when to treat versus when to test. In an unstable mother or a sick child, the next best step is to stabilize and treat, not to order one more study. When bleeding or breathing is the problem, you act first and confirm later. Next, know the signature first-line treatments cold, because these 4 topics repeat them. Magnesium to prevent seizures in severe preeclampsia, massage and a contracting medication for a boggy uterus, and oxygen with a bronchodilator for wheezing. And finally, beware the overkill answer, the impressive-sounding scan or procedure that does more than the patient needs. Choose the proportionate, guideline-based step. Let us work through our first case. A woman at 36 weeks comes in with a pounding headache and blurred vision. Her blood pressure is 168/112 on 2 readings. There is protein in her urine, and her reflexes are brisk. The baby looks fine on the tracing. The question asks for the next best step. Notice the severe range blood pressure and the warning signs before you choose. Read the 4 options and pick your answer, then we will reason through them together. Let us break it down. Spot the pattern first. A blood pressure at or above 160/110, with protein in the urine, a severe headache, and vision changes in the 3rd trimester, is preeclampsia with severe features, and those brisk reflexes warn that seizures could be next. Now apply the rule. This is an emergency, so the next step is to prevent seizures with magnesium sulfate and to bring down the dangerous blood pressure with medication, while planning delivery. Treatment comes first. Now eliminate the rest. Sending her home ignores severe numbers and risks eclampsia. A head scan chases the symptom and wastes time. Reassurance misses a life-threatening diagnosis. The answer is magnesium and blood pressure treatment. Here is our second case. Minutes after a vaginal delivery, a woman starts bleeding briskly. On exam, her uterus feels soft and boggy. The placenta came out intact, and there are no cervical or vaginal tears. Her pulse is climbing and her blood pressure is starting to drop. The question asks for the next best step. The soft uterus is the detail that should jump out at you. Choose your answer, and we will walk through every option next. Let us reason through it. Spot the soft uterus. Heavy bleeding right after delivery, with a boggy uterus, an intact placenta, and no tears, points straight to uterine atony, which is the most common cause of early postpartum hemorrhage. Her falling blood pressure tells you she is becoming unstable. So why does first-line care win? The fastest, cheapest, most effective step is firm uterine massage together with a medication that makes the uterus contract, such as oxytocin. Jumping to hysterectomy is a last resort, not a first move. Ordering a scan before acting wastes time she does not have. Observing an unstable, bleeding patient is dangerous. The answer is massage plus a uterus contracting medication. A quick word on pacing, because this is a 2-day marathon. There are 480 questions across 2 days, split into timed blocks, giving you a little over 1 minute per question. The good news for these topics is that classic obstetrics and pediatrics cases are pattern-based, so quick recognition banks you time for the harder questions. If any single question stalls you for more than about 90 seconds, lock in your best guess, flag it, and move on. Never let one long vignette swallow the time of 3 others. Save your spare seconds, and use your scheduled breaks to stay fresh for day 2. Here is our third case, and this one is all about a single trigger. A 21-day-old baby is brought in with a fever. The rectal temperature is 38.5 degrees Celsius. The baby is feeding a little less, and there is no obvious source on exam. Otherwise, the vital signs are stable. The question asks for the next best step. As you read, pay very close attention to how old this baby is. Pick your answer, and we will reason through it together. Let us break it down. The age is the trigger. A fever in a baby younger than 1 month is a red flag no matter how well that infant looks, because at this age the immune system is immature and the exams simply cannot rule out serious infection. Here is the key distinction. The correct step is a full sepsis evaluation, including blood, urine, and spinal fluid, with admission and antibiotics while the cultures are pending. Reassurance and outpatient follow-up are unsafe at this age. Oral antibiotics at home and just treating the fever both risk missing a serious infection. The answer is the full workup and admission. The age drove the whole question. Here is our fourth case. A 6-year-old is brought in with wheezing and a cough that is worse at night and with running. Right now, the child is speaking in full sentences, is not using extra muscles to breathe, and has a normal oxygen level, with scattered wheezes in the lungs. The question asks for the next best step. Before you choose, decide how severe this is by looking at the speech, the breathing effort, and the oxygen level. Pick your answer, and we will walk through it. Let us reason through it. Spot the pattern. A nighttime cough, wheezing with exertion, and scattered wheezes in a school-aged child fit asthma. And because the child is speaking in full sentences, not using extra breathing muscles, and has a normal oxygen level, this is a mild exacerbation, not a severe one. Apply the rule. For a mild exacerbation, the first line step is an inhaled short-acting bronchodilator, and then you reassess. It is the standard, proportionate move and keeps care in the clinic. Now eliminate the rest. Admission is overkill for a comfortable child. An urgent chest scan is unnecessary for a classic asthma picture. Starting daily controller steroids with no reliever does not treat the wheezing in front of you. The answer is the inhaled bronchodilator. Here is an exam day pearl that ties the pacing advice together, the 2-pass strategy. On your first pass, answer every question that feels straightforward and commit to it. For anything that makes you hesitate, pick your best option, flag it, and keep moving so you reach the end of the block with everything answered. Then, on your second pass, go back only to the flagged questions. This is where people sabotage themselves, so be disciplined. Do not second-guess answers you felt sure about, because a first instinct grounded in a clear rule is usually right. Only change an answer when you find concrete evidence in the stem that you misread it. That wraps up our obstetrics and pediatrics case strategy for step 3. Remember the core moves. Read the last line first, then hunt for the severity triggers. Separate the true emergency from the stable patient and match your answer to that severity. Know the first-line treatments for these 4 cases cold and stay alert for the overkill answer. The best way to lock this in is to drill these cases in your question bank under timed conditions and read every explanation, even on the ones you got right. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If this video helped you, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next one.